Okay. So, the purpose of those lives, and we're going to try to do it on an ongoing basis, maybe once every few weeks, just to stay in touch with you guys, our patients, and, just viewers who want to get some information about the peptide world and what we're doing right now with NexLife as a telehealth company. Is to just stay in touch with you guys, address any sort of questions that you guys might have, talk about the nuances of medicine with the world of healthcare and telemedicine, and just be more interactive with our patients, and to put a face to the name too. I feel like a lot of the companies right now, a lot of them are doing a fantastic job. They sort of like are maybe out of touch with their patients. So what we try to do is to just put ourselves out there, put a face to the name, and actually make sure that you guys are seeing us, not just the videos and not just the articles and not just the posts, and you can actually ask your questions and interact with us. So, Dr. Kennah, we're so
Yeah.
happy to have you. Just to give you guys a brief background about Dr. Kennah, he's a board certified emergency medicine, I'm not mistaken, and
And
certified
obesity
in 50
medicine.
states. Yes. And we've been working for the past couple months, and you've had more than 10 years of leadership and directorship experience, more than 8 years of experience in telemedicine, and you're licensed in many, many states. And you're an educator.
Mhm.
So, Dr. Kenna, could you tell us about your, like, I don't know, like educational experience, going through med school? Have you ever had it like a time in your life where you were like, educating other people?
Sure. Yeah. So, basically, going through emergency medicine, we worked a lot with residents and med students and PA students and PAs and nurse practitioners. So, always, educating, teaching on the job, doing lots of lectures and classes. I was a kind of adjunct professor at South University for their PA program, so
Mhm.
did some education and courses for them. So, and then speaking at conferences and all sorts of other things. So, lots of
That's so
talks and
exciting.
educational experience. Yeah.
That's so exciting. And I feel like education and being an educator is an integral part of medicine. And that's
Mhm.
something that anybody venturing into this field would have to be taking part of. So let's get started with some of the questions.
Sure.
We've received some questions
Yeah.
on DMs. And so just generally, I believe one patient asked, like, how does the GLP-1s actually work? And in
Mhm.
specific, like, the microdose, right? Like I
Right.
understand like GLPs are the peptides, right? And they're sort of
Mhm.
the agonist that allows your body to, produce certain type of reactions in an amplified fashion. Obviously, we have the GLP-1 receptors in our, GI tract. But just to get into your head, like, what is your definition of peptides in terms of like GLP-1s?
Right. So, peptides broadly are generally things that your body already produces that we are just replicating either the exact same, basically like hormone type hormone type molecules that are produced by your gut. So after we eat, they're released to tell your brain, hey, we ate already, we're done for a while. Let's digest what we've eaten. So basically, we're replicating that feeling of having just eaten so that you're not always as hungry, and also puts your body into a mode to try to utilize the things that you just ate. So we're trying to trick our body into being, out of kind of hungry starvation mode and
Mhm.
into a mode of, we just ate, so we don't need to eat anymore, but also need to utilize the things that we've already eaten. So it does help kind of control hunger, but also helps increase the use of stuff that we already have floating around in our body. And that's how it helps sort of, chew up fat, reduce the amount of, fatty liver, fat around your belly, also increases of your insulin usage. So it does reduce things like insulin resistance. That's why it's very helpful for things like diabetes.
Mhm.
Insulin is also a peptide. Same thing. It was secreted by the pancreas after we eat. So we replicated that again to kind of control diabetes. This a little less effect on the diabetes, more on the weight loss end, but does both just the same.
Right. And that's very interesting because if I'm not mistaken, the medications were first approved for diabetes,
Correct.
and for those who are in healthcare, like you learn about like liraglutide or some of the earlier names. that came and hit the market, and then you then the semaglutide was introduced, and tirzepatide, which was a dual agonist, and now we're going to have potentially a lot of like that the retatrutide, if I'm not butchering its name, is going through its full-on
Hmm.
FDA process, which is a triple agonist. Essentially, what
Hmm.
they did is that they added some glucagon into it.
Right.
And for those who don't know, glucagon is just going to make you feel like, okay, well, there's sugars missing, so it helps your body to break down sugar and
Right.
glycogen storages, and so that helps with like getting rid of that visceral fat that Dr. Kennah was alluding to. So it's very interesting, and a lot of people, like some of these people who are maybe not like doctors but maybe PhDs, are heavily in for tirzepatide or some of the peptides right now that are hitting market, and they think like it's like miracle drugs. I personally think they are very good drugs, but they're not going to be miracle drugs. They're not going to like change your whole life. Obviously, you're
Right.
going to have to, do some work on your end. It's something that we've been trying to push for, getting our patients on our Care 360 program, which essentially means we're there for you every step of the way, and that you're not just injecting yourself with a certain peptide that, as much as we say it's a good thing, as much as the data supports it and shows results, but you're also complementing it with exercising, with dieting, that you maintain your muscle mass. I think I was
Hmm.
reading somewhere that muscle mass in and of itself burns a certain amount of calories even when you're
Right.
sleeping,
Yeah.
right?
Yeah.
Um, so that was something that was very interesting when I was reading into it. One of the other questions that was, a lot of people were asking in our Reddit channel, a lot of people were tapping into, was GLP-1 microdosing,
Hmm.
right? So the New England Journal of Medicine, which is one of the most, I think, if not the most prestigious journal that a lot of doctors are like, usually like look into it. After that would be Nature probably, but. Um, it was showing that there is a good amount of efficacy shown even with a microdosing,
Hmm.
if I'm not mistaken, anywhere between like 15 to or 19% for like the dual agonists such as tirzepatide. So what's your take on microdosing, Dr. Kenna? Like, what do you think, like, if should the patient get on microdosing? If so, when, at what BMI should they be thinking
Right.
about microdosing if they are actually a candidate? Because obviously, we can't just give it to everyone, right? You have to
Right.
be a good candidate. You don't have to have certain biomarkers, and like you don't have to have MEN1, which is means like you're going to get certain type of cancers. But so, what's your take on
Mhm.
microdosing in general?
So for me, I think microdosing really fits into three sort of categories
Hmm.
as to why you would do it. But first, we talk about GLP-1s or all of these weight loss medications. I always think of them and describe them as a scale. So our body, inside our brains and our bodies, there's a constant fight between parts of us that want to gain weight and part of us that wants to lose weight. So kind of the evil
Hmm.
and good sides, right? So for people that struggle with obesity, basically that's been tipped to the evil side, right? So we're constantly gaining weight, and that's why people gain weight more and more and more as they age. And things obviously, tip that in other directions. Hormones, perimenopause, you hear about that.
Hmm.
Decreased activity, decreased muscle mass, that can kind of tip it more in that direction. These medications basically push on the good side of the scale and kind of eventually tip you over either to even or to the weight loss
Hmm.
uh, side. So again, with these medications, not uncommon. People that have a pretty heavy, you'll say evil side, takes a lot of medication to really get to the weight loss side. But with microdosing, what we're kind of aiming for is more of a balance, or maybe a little bit slightly to the weight loss side, but more of a balance. So for microdosing, the three things I think about is one, people who have been on the GLP-1s for a while
Hmm.
and have lost weight, and they're now at a comfortable weight and just want to maintain. So they don't want to stay on the super high dose. They want to just sort of maintain. So instead of being in this negative balance, we go into more of just a balance.
Hmm.
So microdosing is great for that. It's also for people, let's say, who maybe didn't use GLP-1s, but have gotten themselves however, into a healthy BMI and just want to stay there, right? So we're trying not to lose weight, right? Because we're kind of at a healthy weight. We don't want to get into an unhealthy low weight. So we say we're below sort of what we consider a treatment BMI, which is generally 27 and above.
Hmm.
So if they're in the healthy range, and let's say that, the 20 to 25 range, so they don't want to lose weight, but they don't want to, gain weight. So they'll kind of stay in that balance. So microdosing is great for that. And the third part, kind of what you discussed, there's lots of benefits that we're finding to these drugs outside of the diabetes and the weight loss, right? People use it for anti-inflammatory properties. People that have Crohn's or IBS or polycystic ovarian syndrome have found that these medications are great for kind of calming down inflammation. We've
Hmm.
seen benefits for heart disease, we've seen benefits for Alzheimer's, we've seen benefits for dementia of all causes. So let's say you don't need to lose weight, but you want to have those sort of anti-inflammatory benefits, microdosing is perfect for you. Because again, we don't want to put you on higher doses to put you into an unhealthy,
Hmm.
status, unhealthy weight. So if you're at a healthy weight and either want to maintain or want to have that, other benefits, microdosing is perfect.
Hmm. Yeah, certainly. Because right now there's a lot of buzz around the word microdosing, Tirzepatide and Semaglutide, and so it is really good to know that there's that other option available to some of the patients
Mhm.
who don't want to get on the full dosing, and I think by extension maybe some of the side effects are going to be a little bit less, and
Right.
and the fact that people who want to be on a maintenance dose or want to slowly and gradually taper off their intake of the GLP-1s, they could utilize that sort of protocol
Mhm.
to just minimize it and then down the line completely get off of it.
Mhm.
And that's what we're aspiring for. Um, so one other question, Dr. Kennah. So that we've been getting from some of our patients, like obviously from patient to patient, and their metabolism rate, their sex, their gender, and their age. All of those components are significant components of how responsive they are to a medication,
Mhm.
their habits, everything else. But generally speaking, what do you think is the biggest reason why somebody would lose, for example, 50 pounds versus somebody else who's losing 10 pounds?
Mhm. Again, it goes back to that scale.
Hmm.
So, like I said, some people, again, like you mentioned, hormone balance, um, uh, a couple of chronic diseases. So, if they already have insulin resistance, they're diabetic, they have high cholesterol. Um, some people are just already in a pretty high negative balance. So,
Hmm.
flipping that over, they tend to lose a lot more weight once you sort of overcome that. Um, and some people just, everyone's baseline weight is different, right?
Hmm.
So we use BMI as a general, term, but BMI is not the be all end all of your weight.
Hmm.
For example, you look at someone like The Rock, right? The Rock probably weighs what, 280 pounds. So his BMI, if you calculate it, is probably in the obese range. But he's not obese, right? We know he's not that. So everyone, based on their skeletal mass, their bone, the muscle mass, their BMIs are somewhat different. So if you have someone who sort of has a smaller, let's say, bone density, smaller muscle mass at baseline, and they weigh the same as someone who has maybe more bone mass and more muscle mass, they have more weight to lose. So they tend to lose kind of a lot more weight than someone who, again, has sort of, again, less weight to lose. And
Hmm.
so that's generally what we see.
Okay. And one other interesting thing that I was talking to some of my colleagues in medical school regarding GLP-1s and alcohol cravings. Um, a journal came out on 2026 that was doing a randomized
Mhm.
control trial on semaglutide, which is only just like the monoagonist one.
Yeah.
On the people who are taking that once a week as an injection, it seemed that it reduced the alcohol cravings by about 41% or so.
Mhm.
Do you think that is more so attributed to the dopaminergic pathway in the patient's brains, or is it that they just when they're consuming alcohol and they're on these GLP-1s, they kind of like feel nausea and they don't really want to handle it that well?
Mhm.
Which one is it? Is it that the reward pathway, or is it the just not being able to handle it because of the
Right.
peristalsis and everything else that's
Yeah.
going on with the GI tract?
Yeah, I think it's more the reward pathway. There's been a lot of research and a lot of things we discovered with the connection between like addiction treatments
Hmm.
and weight loss medications. Before GLP-1s, we often used medication called Contrave. And
Hmm.
Contrave was a combination of basically Wellbutrin, which is an anti-depressant, anti-anxiety medication,
Yes.
and naltrexone, which
Hmm.
is a medication often used to treat drug and alcohol addiction. And they
Hmm.
found that actually this kind of calmed cravings. So
Yes.
cravings are cravings not just for food, but for other things that we may have, again, kind of unhealthy reliance on. So
Hmm.
I suspect a lot of this is that calming down the dopaminergic path, calming down sort of that craving pathway, as it were. So if
Hmm.
you're craving things like alcohol, it will kind of help reduce those cravings. If you're craving things like sugary snacks, foods, late night meals, both treatments, treatment, addiction treatment and kind of weight loss treatments kind of help kind of cover both.
Hmm. Okay, that's very interesting actually, because I've been thinking about it and I've been talking about it with a lot of my friends about this topic, and it was something that was in my head.
Mhm.
Um,
And
and what?
there actually
Yeah.
has been research into pairing kind of what they call low dose naltrexone with GLP-1s and the added benefit
Mhm.
that causes for weight loss. So a lot of people that are stuck, let's say at max dose, or they're having side effects, sometimes adding like a low dose naltrexone does help a little, push you for a little bit further. So again, there is that sort of synergistic effect between the two.
That's very interesting. Very interesting. And one other question that is sort of like the things that I talk to my colleagues about, and it may not be a general question, but it's the conversation around PCOS, or as some people call it, PCOS or PBOS, that's now recently been renamed.
Yeah.
Obviously, these patients, they have certain amount, like certain issues. But to get started, like, how would you describe the PCOS to the patients that they would understand?
Mhm.
And then after that, I want to know, like, how do you think GLP-1s are going to be helpful to these
Mhm.
patients who
Mhm.
are, experiencing this sort of like medical conditions?
Right. So I think what we're finding is that PCOS is actually more of a metabolic syndrome.
Hmm.
The end finding were the cysts on the ovaries.
Hmm.
And so that's how it got the name polycystic ovarian syndrome, because we would find these cysts on the ovaries and say, you have PCOS. But now we're sort of understanding that all of this ties together through a general sort of metabolic dysregulation. With the PCOS, we tend to see increased androgyny. So women with, facial hair,
Hmm.
striae or stretch marks, discoloration of the skin. You also see insulin resistance very high, which doesn't make sense if it's just a cyst on the ovary. There's something else going on. So it definitely is much more of a metabolic derangement, which is why it was renamed. And then the GLP-1s kind of target that metabolic kind of source of the problem. So we're not just treating like the ovarian cysts. That's more the symptom of the overall problem. The overall problem is metabolic. And that's why the first treatments were metformin. Metformin is sort of like a GLP cousin. It works a lot in the same way, much less effective. For all these things in the GLP-1s, but it does have the same sort of, regulating metabolism effect. So again, that's why we see that these medications help off a lot of other symptoms of the GLP-1s besides just the weight gain. The weight gain is just a symptom of the underlying problem, as are the cysts on
Right.
the ovaries, as are all the other things.
And I know a lot of them are prone to getting type 2 diabetes because of, receptor
Mhm.
insensitivities and things of that nature. So it's very interesting to see like that this medication, which essentially affects the individual's metabolism, can have a multitude of effects across the
Mhm.
board with so many different medical conditions. Um, Now, the general question that a lot of people have, and I always try to explain it to them as this, and please correct me if I'm wrong.
Mhm.
Taking steroids is like drinking out of a fire hose, versus peptides is kind of like the switch where you turn on and off, or at least your body has the capacity and the ability to be able to turn it off and on. Um, or like, how would you describe the difference between peptides and steroids for our
Mhm.
audience?
So I guess it depends on what type of steroid you're talking
Hmm.
about. So if you're talking about things like prednisone, basically we are uh, things like prednisone, cortisol, things like that, kind of increase the stress sort of hormone effect in the body. So it's a very similar idea of the GLP-1s, and kind of those types of steroids are very similar in that we're replicating something that already occurs in the body and just ramping it up. So,
Hmm.
things like prednisone, we're ramping up the stress amount of the body, the stress response of the body, right? So we go into that sort of, again, insulin resistance mode. We go into weight gain mode. We're trying to like get ready for a battle or for a fight. Whereas GLP-1s, we're activating the other end, right?
Hmm.
We ate, we're calming down, we're going to burn all this stuff. We don't need to eat anymore. So they're sort of two edges of the same coin, basically, or two sides of the same coin,
Hmm.
just kind of competing against one another.
Right, right. Yeah, I mean, like that's like very interesting because so many people still think that peptides and steroids are basically the same thing. Now, yes, they both are involved in the signaling pathway, and they're going to have like certain amount of like changes to your body, but obviously there are differences amongst the
Yeah.
two, and that's why I
Now,
think, uh, yeah.
if you're just so peptide is a broad term, right? So peptide covers a million things, anything
Hmm.
from insulin to, you know, to all kinds of other stuff. If we're talking about like longevity type peptides, things that people are using for longevity, muscle
Hmm.
mass, or Smorlin, Tessamorlin, the difference between like a steroid, what you think of like an Arnold Schwarzenegger steroid, versus a peptide, those types of steroids. If you think of the body, the brain releases chemicals which causes other chemicals to be released. For example, testosterone, right? Your brain releases chemicals that cause other parts of your body to release testosterone.
Hmm.
So like an Arnold Schwarzenegger type steroid is just pure testosterone, right? There's
Hmm.
no regulation. I can't really turn it on or turn it off. So I'm adding the end product directly into my system.
Hmm.
And that, if it's not done properly, you can add way, 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 way too much, and really cause some issues. Whereas the peptides, when you think of things like tesamorelin, smorelin, things like that, they act on the brain to kind of trigger more downstream effects. And then your body is sort of capped. It can only do so much. So we're triggering the body to release, let's say, more growth hormone, but it is sort of capped at how much your body can release. So it's really hard to kind of overdo it. It's just kind of giving yourself a little boost. And GLP-1s are very similar, right? You really
Hmm.
can't, your body can only absorb so much of it and use so much of it. So even if you take super high doses, it kind of hits a point where it sort of caps off on how much it can affect and sort of
Hmm.
ends there. So if that's what you're talking about,
Right.
that's the
And I love
explanation.
that you touch base on testosterone, because that's something that we're going to be,
Mhm.
bringing on later on as a part of our longevity protocol, and our in our system as soon as our website gets
Yeah.
updated and everything gets nice and tidy. But yeah, to our viewers, as Dr. Kennah mentioned, growth hormone is just basically the end product, versus the testosterone is like that, just amplifying your body's natural ability to produce that, IGF hormones, and the growth hormones. So that's sort of like the difference for those who are concerned. Dr. Kennah, the one of the main questions that a lot of people are asking, and that's one of the main challenges, or maybe partially one of the challenges that we are facing right now in our healthcare system, is patients' sort of distrust the in a way the bureaucracy of medicine per se. I don't want to call it that. Nothing too controversial, but there's still a lot of things that needs to be addressed when it comes down to rules and regulations for approving certain drugs, that a lot of people are right now like seeking care, or like they're getting their medications from certain type of companies that are not even registered in America. For
Right.
example, the famous the Chinese research grade peptides that they're getting right now. But they're the same people who are maybe are a little bit more skeptical about the things that we right now have in our medical system, like the vaccines and things of that nature, that have gone through so many rounds of FDA approval. Where do you think, in your perspective, that sort of distrust is coming from? Is it more of a financial situation where they think that, okay, well, the insurance companies are in a way screwing me over. They're charging me so much, and I have to pay, and I have to go above and beyond to be able to get the basic care, and so I'd rather just get my medication from like other sources, Chinese companies, or like the research grade companies. Or is it more of a are we like entering a new phase where people are just seeking alternative care that is not necessarily evidence based, and it's more so maybe social media based? Like, what
Mhm.
is your perspective on this?
I think it's a mixture of all of that.
Hmm.
So first off, to actually have your drug FDA approved is extraordinarily expensive. It's a massive undertaking. And for a major company, they'll have 10 or 20 products go to the process to have one come out at the end successful. And that's, tens, if not hundreds of millions of dollars to get to that one drug.
Hmm.
So they do overprice that one drug, trying to make up for all the other, failures basically that they had, and to try to fund development of the next product. Now, are they
Hmm.
overcharging it for profit? Absolutely. right? But again, trying to get through that process is very expensive. So creating these drugs, coming up with these drugs is a major undertaking. Um, so people are always, when something like Tirzepatide comes out, people want those medications, but they don't want to pay these super high inflated prices, and that's where compounding pharmacies comes in until it goes, generic. Um, the other side to that is there are lots and lots and lots of drugs, medications, peptides, whatever you want to call it, that aren't under copyright, right? So whoever puts the money in to go through the process to get it FDA approved, everyone can use it, right? It's
Hmm.
in public domain. Anyone can use it. So things like the peptides, right? So things like NAD plus or more tesamorelin. No company is going to try to get that FDA approved because there's no money in it for them at the end because they can't copyright that drug at the end. So if they go through the whole process and they can't make any money from it, then there's no point. So these drugs will never go through FDA approval,
Hmm.
no matter what, because there's just no money in it. So it doesn't mean that they aren't effective. It doesn't mean they don't do something for the body. It just means that no one's going to put the money in to run the giant study that's going to prove it.
Okay.
So the question is, when you're looking at things like this, like, is there enough evidence that shows that maybe that there is some effect? Is there enough evidence that shows that it's not dangerous, for us? If there's enough evidence of that, is it safe as something I'm willing to try without knowing exactly, you know, with a giant study behind it, if this is going to work or not, or how it's
Hmm.
going to work?
So do you
I think.
foresee like maybe in the future, in your perspective, like maybe with the help of AI and some of the new technologies that are hitting the market, would it be a phase where patients could have potentially access to important medications, like not just the peptides, maybe like life-saving medications earlier in the phase? Or do you think that because of these because like I believe, if I'm not mistaken, the phase threes where most of the drugs are failing, where they would have to do on so many different demographics
Yep.
testing, and not only assessing for the efficacy but also all the downsides, and there's the certain dosages, and then just like cross balancing it to see if it's even viable, or if it's even
Mhm.
worthy for it to hit the market and go into phase four. And funnily enough, a lot of the medications that are actually marketed are still in phase four, and they get pulled from the market.
Mhm.
And there for the audience who don't know, and a lot of them will have like black labels and such. But do you think that down the line, with the help of technology, these medications could be more streamlined into the market, or because you still have to see and assess every single patient, it
Mhm.
would be a delay still, like a
No, I
10-year
think.
delay before a medication that is crucial is hitting the market?
I think we're a ways away from that point, but the more we can recreate the human body experience,
Hmm.
the less we have to test on actual humans. If you think back even 15 years ago, there was a project called Folding at Home, where they tapped into computers all around the world to basically create proteins, right? So they would use the chemical properties of the proteins
Right.
and figure out how they fit together. So instead of doing that by trial and error at the bench, they use the computer power from around the world to be able to create these proteins, basically out of data. So that saves an immense amount of time. So things like that, as we sort of are able to use the computing power to sort of recreate, how we react within our own body. And yeah, these things are going to be streamlined and come out faster.
It's very interesting. Yeah, I'm looking forward to the day where people can actually like, have access to those medications without having
Mhm.
to go through like so much, and we have a bit more I guess fast tracked version of getting some of these medications that are crucial in the hands of the public.
Mhm.
Because yeah, like I feel like the GLP-1s, the ones that we have right now, they've been out since I think more than a decade ago, and only now you have sufficient data to support it, and you can actually like give it
Mhm.
to patients. Uh, so glutathione, it's something that I'm personally very interested in. It is by far, if I'm not mistaken, the most powerful antioxidant that our body naturally produces.
Mhm.
Um, and this is something that we recently brought in as an add-on, and we're going to be incorporating that into our longevity protocol. Um, what do you think? Do you think like people should be on glutathione? If so, what demographic would get the most amount of benefits from glutathione?
Mhm.
Um, and just what is your general thoughts on this, and how should it be administered and things of that nature?
Yeah. So again, with all of these sort of peptides, there's things that either replicate or are naturally occurring inside our body.
Hmm.
And again, it's one of these things that is not under copyright, so no one's ever going to fully study it. So we do have evidence that it does reduce inflammatory responses, but we don't have a big giant study that shows,
Hmm.
it reduces this by 10%, or it reduces weight, or reduces weight by 10%, or whatever. And we probably never will.
Hmm.
So I think, for people interested in things like that, it's really important to, take a look, ask questions, I say do your own research, but look around and try not to do it on sites that are trying to sell you huge markups on it. But look around, and see if you want to try it. And I think, we have at least enough anecdotal evidence, because it's been used for many years, that it is safe, or is relatively safe. That there aren't any major issues with it. And if you're willing to try it, try it. And I think trying at a lower dose, generally injection is the most effective way of getting it into your system. But definitely work something to add into the body,
Right.
to help, again, anti-inflammatory changes, antioxidants. So this research into aging is still extremely new, again, because we kind of have been focused for millennia on fixing problems, and this is sort of a new generation, as it were. As people are living longer, we have people in our 90s, people in their 90s that are completely functional and active, and we never thought about, how do I live into my 90s and be, active and functional, because it just never was an issue until now. So we're finding things like, oxidative stress, chromosomal damage, inflammatory changes that cause kind of long-term kind of telomere damage, things like that, that are going to age us as
Mhm.
humans. And
And
so,
for those who don't know, what is telomere? Because it's very interesting. Just for our audience to know what telomere
right.
is.
So just in kind of a broad term, our bodies were born with certain chromosomes, and our bodies are constantly replicating that. So basically, splitting it in half, duplicating it, splitting it in half, duplicating it, splitting it in half, duplicating it, and over time, you make copies of copies of copies of copies of copies. You tend to lose pieces. You tend to have damage, and
Hmm.
that's one of the ways that we think that aging occurs. That over
Hmm.
time, you're making a copy of a copy of a copy of a copy of a copy. You're kind of adding on to the damage, and that's how our cells become less vibrant, less youthful over time.
Yeah. I think one of the strongest hypotheses was they examined the telomere length of the older
Hmm.
individuals versus the younger individuals, and they
Yeah.
realized that there's a bit of a correlation in that regard. And it's something that's very interesting to me. I was geeking out on telomere length and telomerase and reverse transcriptase and all those buzzwords, but for our audience, and that's something that I always try to like tell our healthcare specialist team, the ones who are talking to the patients about glutathione, is that, well, glutathione was first introduced for people who were on like platinum-based compounds, aka just chemotherapy,
Hmm.
and they were having like some neuropathy, some damages because of oxidative stress that these medications put you on. And so that's where glutathione first was introduced as a very strong, I guess, antioxidant to mitigate some of those damages. But then
Hmm.
again, as Dr. Kind of alluded to, there's no comprehensive data on this, and for a variety of reasons, right?
Hmm.
And such, for many of the medications that we currently have, there's not much of a comprehensive data on it. But hopefully, maybe down the line, as more and more attraction comes its way, maybe there will be more maybe comprehensive studies on it. But I find it extremely unlikely, um, for the same reasons
Right.
that you just mentioned as well. Dr. Kennah, so for specifically for our patients, because we're going to be recording this video and
Hmm.
we're going to like clip out some of the good stuff out of it and putting it on our Instagram page, and maybe like some of the other
Hmm.
pages. We've created a website called NexLife RX. Okay,
Hmm.
and I want everybody to go check it out. Whenever you see this video, I really want you guys to go check it out. It's called NexLife RX. it is still getting optimized as we speak, but this is sort of a website that anybody could be benefiting from. This is a website where, we have all the dosages from different compounding pharmacies and with different concentrations. So I personally think that our patients could be, accessing that website, seeing all the orders that have been approved by our internal medical team, and seeing that, okay, well, if you're at this dosage, or if you're using this sort of like, pharmacy, if you're using like Absolute Pharmacy for Tirzepatide and what
Hmm.
have you, this is the sort of like, dosages that you could like, you could take as just your general guide. But obviously, like most of the dosages are tailored for our patients. So whatever you order to our patients or our other medical team, that's what they would have to follow. But that's something that we're really passionate about. And I think that's going to reduce maybe some of the workload that our internal team
Hmm.
and you specifically
Right.
might have in the future. So patients could be like literally accessing the website and clicking on their medication, the picture of their
Yep.
medication, and seeing the dosage. So we're really excited about that.
Yeah, I think that's one of the big problems with this space is that every pharmacy compounds it differently, so it's different strengths, and I think patients often get or aren't sure exactly what dose they're taking.
Hmm.
So the one vial might have twice as much of the medication in it than another vial does. So therefore, you take less of it. But when you tell someone you're going to go from 20 units to 10 units, they think, well, I'm taking less medication. But you're like,
Hmm.
well, actually, no, you're taking the same, maybe even more, because what you were taking before was mostly water. What you're taking before now has more medication. And it's really just the way the pharmacy decides to do it, whatever works best for them. There's no right way or wrong way to do that.
Hmm.
Lots of very reputable pharmacies have 10 milligrams of tirzepatide per ml. Some have 30 or 40. It's just the way that they want to compound it, what they see as sort of their
Hmm.
best market, basically.
Right.
So trying to calculate that back is a problem. And people that are coming into the program tend to get frustrated because they have to send pictures and photos of their things, because we want to make sure that we know exactly what dose you were on so we can tailor it appropriately. Because the people that we generally see that get very sick on these are ones that are overdosed.
Hmm.
So they think they're on this high dose, they aren't really, and so we kind of prescribe them that when really they run a really low dose, and they make that one big jump, and that really hits them like a ton of bricks, and
Right.
then they're throwing up and they're nauseous. They feel like they feel terrible for a week or so. So trying to make sure you're on the right dose, that we have you on the right dose when you come into the program is important.
Right, 100%. I totally agree with that. And I don't know why the company pharmacies have different concentrations, but I'm sure they have their own reasonings. But every compounding pharmacy that we've looked at, they have a different sort of
Hmm.
concentration. And it's not to say that it's not effective. Obviously, all the compounding pharmacies that we're working with, we're thoroughly vetting them ourselves, and we try to like even sometimes like meet up with one of the reps, or even one of the people who are in the compounding pharmacy in that industry, to just to make sure that everything is in part with our standards. But yeah, like they have their own concentrations, they have their own dosing, and so it could get very confusing, not only to our patients but also for me. Like I remember one time I was trying to like address one of the patient's concerns, and I was like having to like chat GPT it, like look into it. I was like, okay, well, this is the picture of the vial, so I'm assuming it's like 68 milligrams per vial per this many milliliters. So if
Hmm.
you're supposed to be taking like 3 milligrams per dosage, this is how you got to do it. And I was just reporting it back to our internal team to
Yeah.
relay it to our patients. So yeah, so hopefully that website is something that I think everybody can check it out. Again, whether you be working with us or a different company, you have to always follow your doctor's guidelines. Hopefully you're working with a doctor, and that's what what it has
Yes.
to be, right? So hopefully you're working with a doctor, but regardless, this is a website that I think everybody could benefit from. And yeah, so it has the general guidelines that we've approved. That doesn't mean
Okay.
that it's going to be applicable to you guys.
Right.
However, this is something that our patients and other people from who are getting their medication from different parts of
Mhm.
the world or a company, whatever, they can benefit from that as well. So
Mhm.
we're really excited about it.
Yeah.
And um,
There
Dr.
was some.
Kenna,
Oh, I'll say that. Go
uh,
ahead.
yeah, go ahead.
No, go ahead. Go ahead.
Yeah, so I was gonna ask you about muscle mass
Yeah.
and muscle loss,
Yeah.
because that is something that I've been trying to do my very best to push for whether it be the videos that we're making with Care 360 team, and we're
Hmm.
trying to optimize it as much as possible. We're even offering a free Care 360 session to all of our patients. We're sending them, nutritions and so many different things that they could benefit from. However, at the end of the day, most of the patients would come to us usually for our medication and for our services, and less so for the entirety of the care that we could provide,
Hmm.
right? And we're not just a company who would just send you the medication and just say goodbye. We have monthly check-ins for our patients. They constantly are communicating with us with a text or with calls, and we have a team of people that are almost always on call to address their patients. We recently
Hmm.
hired a nurse that you trained, so we're really excited about it. We're trying to like communicate with our patients to get them, like, my goal is to get the patients on and off the medication in the best possible way.
Hmm.
And in doing so, I think personally the most important part is to make sure they're increasing their muscle mass and they're decreasing their BMI to a healthier way. And as you mentioned, like a rock could have a BMI of like 250, but that doesn't have
Hmm.
any fat. But so how do you think the patients could maintain their muscle mass?
Hmm.
um what should they actually do? It is easy to say to the patients that, okay, go eat a lot of protein, right? But when they're on GLP-1s, when they've already been tuned to like the bad habits, right? They may or may not be more inclined to completely change their life around, like in a snap of a finger.
Hmm.
Obviously, that is our hope because they can get on and off the medication the sooner. But what is your message to the patients? Like, if you want to preserve their muscle mass, first of all, how important it is, and second of
Yeah.
all, how do you go about it in doing it, communicating with the patients?
Right. Actually, I was going to interrupt you. We had a couple questions that all sort of in the chat here that sort of
Yeah.
fed into that. So it's perfect sort of transition. So, so the first bit is anytime you lose weight, whether that's for whatever reason, medication, surgery, whatever, your body not only eats at fat, it eats at anything available, and muscle is one of those things. If you're doing nothing and just losing weight, your body will eat at the muscle tissue. So you will lose muscle. Muscle is important for a couple of reasons. It basically is one of the biggest users of energy in our body. So when we talk about our daily calorie burn, right? The muscle mass is one of the um, big parts of that, big drivers of that. And like you said, it burns calories while you sleep. Yes, it does, because it takes a lot of upkeep to keep that muscle
Hmm.
functioning and going. And then someone who has more muscle, if they just lift their leg, they're using more muscle, therefore more energy to do that. Even a very simple thing like walking, right, takes more energy if you have more muscle than if you have less muscle. So you're burning more calories with every step than you are if you have less muscle. So the goal is, number one, to avoid loss, and number two, try to add what you can, because again, that does reduce it. It reduces the amount of, or actually increases the amount of calories that you burn daily, and helps reduce kind of your weight, right? It helps improve your weight loss. So when you're on a medication like this, and the same thing like with bariatric surgery, if you've had surgery and you're losing a lot of weight, suddenly they tell you the same sort of thing. Number one is increase your protein intake. So the general consensus is about 1 gram per kilogram. So a kilogram is about roughly half your weight, a little bit less. So if you weigh 200 pounds, the half that's 100, so maybe about 90. So you should have about 90 grams of protein, which is a lot. It's a lot of protein to take in, but it's important to try to get to there, or at least close to there. To try to, again, to prevent your body from eating at the muscle, right? If we want to eat at fat, not the muscle, more protein kind of helps protect that muscle so that we're not, it's not as attractive a target for your body to kind of eat at. Um, Someone in chat asked, how do we eat calories even if we're not hungry? And it kind of ties in with this, which is trying to focus on proteins, which are a little more calorie dense than, empty carbs. Um, but things like shakes, things that are kind of dense in calories and dense in protein, but aren't dense in aren't have a lot of size, right? It's easy to drink, an Inshore shake or a protein shake or anything like that, because it's got a lot of protein in it. It's not a lot of volume, so you're not eating a ton, but you are getting your calories. You're getting your calories, you're getting your protein, you're getting the things that you need. That's where things like Swim Fast shakes come in, right? Because they have vitamins, they have the protein, all that stuff. And then same idea there, trying to get everything in one small volume of food. So that way you are meeting your protein goals, you're meeting your calorie goals, but you aren't eating, tons. Um, making simple changes to your day, trying to substitute out, things that are a little bit more dense in proteins, a little lighter in proteins. If you like yogurt, especially like a Greek yogurt, so a little bit more protein in it, a little less sugar in it, maybe mix in some like protein granola or something like that in the morning. Um, look at things that you eat frequently and see how can I substitute out maybe a little bit more protein, a little less carbs, which also helps with a lot of the side effects that we see with these medications. So increasing protein intake is important. The second is doing some type of resistance exercise. So you don't need to be lifting weights. You don't need to be doing heavy weights, but some kind of resistance. So bands are the cheapest, easiest things to get. You can buy them, at Walmart for like $10 and list a thing of bands, and just, stand on the band and do a curl. Stand on the band and do a squat. Things like squats even. Resistance against your body weight resistance is great. That's putting stress on the muscle. When you put stress on the muscle, it's a trigger to your brain that I actually need this muscle. I need this. Don't take it away. If you aren't stressing it, if you aren't using it, then your brain thinks it's extra and can get rid of it. So any sort of resistance training is ideal, at least 3 or 4 days a week. There was a pretty good study recently for people who, let's say, work at home or have a sedentary job, that you can actually have a lot of benefit just from doing 10 squats every 45 minutes. So take a break, take 10 squats, takes 10 seconds, right? Just stand up,
Right.
squat 10 times, body weight, sit back down. It has the same metabolic and weight loss effect as walking for 45 minutes a day. So you
That's very interesting.
do that 10 seconds every 45 minutes. So you do it whatever 10 or 12 times during the day when you're at work. So people that have sedentary jobs like me, who sits in front of the desk and sees patients, every 45 minutes, stand up, do 10 squats, sit back down. Those sort of little, they call them snacks, right? These are like little exercise snacks. Instead of doing a full workout, a very quick little exercise snack. Helps maintain the muscle because, again, you're doing resistance. Your body weight is the resistance in that case. You're not using the band, but just the simple squat works. And it's a study. You can look it up. You can search it. It's been published. So it's something that that I do, that we do. So again, resistance exercise is extremely important. You don't have to work out heavy. You don't have to do anything crazy. Just some bands, some squats, something that tells your brain, I still use this muscle. If you do a lot of walking, put some cans of whatever inside your backpack and
Hmm.
take it for a walk. That added weight, that added resistance helps a lot. Which actually brings to another point of why do we stall out on weight loss, right? Why do we lose weight when we stall? One of the key points of that is that as you lose weight, you're losing natural resistance, right?
Hmm.
Walking when you're 250 pounds takes a lot more energy than walking when you're 180 pounds. So when you get to a certain weight, you're actually using much less energy doing all the things you normally do. So I usually recommend, as you start to lose weight, start adding weight to your walks, or even just during the day. If you're up doing vacuuming, plus I put a backpack on, put some ankle weights on, something to kind of add weight, kind of mimic the way you were before you lost weight. And so you're still burning the same amount of energy, you're still using the muscle the same, helps break through those plateaus.
That's very, very helpful, and it's so interesting. I didn't know that a couple squats could actually like increase your metabolism by such
Mhm.
big margin, and it's good for our reviewers because like a lot of our patients, um, they are having a hard time going to the gym. They have certain obligations in their lives that would probably hinder them from going to the gym on a regular basis. So that I think is certainly going to be very helpful to them. And thank you so much for that. Now, couple more questions that we have, and I want to let you go. I want to be respectful of your
Yeah.
time. Thank you so much. Um, so one of our patients asked, "Is Tirzepatide combined with anything else, or is it a singular product?" So that's one of the questions that a lot of people are asking. Is it now combined with glycine?
Mhm.
And what is glycine? Is it glycerin? Am I injecting myself with fat? No, glycine is just an amino acid. Is it combined with vitamin B12, or why is the color now yellow? Well, B12 is just vitamin B12. You take it off the counter, you can get it anywhere. Is it combined with NAD? I've heard NAD is the expensive stuff. It's the good stuff. Can I get the NAD version? And by the way, for those who don't know, NAD is just a part of your, your energy cycle. It's got Krebs cycle. It's going to be helping you with, producing a certain you with, producing a certain, things that would help you make more ATPs, which is it, or why should they not be concerned about it?
hmm So this is really a legal issue, right?
Hmm.
So because these medications still have brand name options available and are still under copyright, like we talked about before,
Hmm.
it is technically against FDA regulations, technically illegal to offer these medications at the same dose and by itself, and or by itself, than what you can buy, with the brand name option. The thought being, if the patient can use the brand name dose with nothing added, then they need to use the brand name medication.
Hmm.
So when you're using a compounded pharmacy, we have the ability to tailor dosing a little bit more. So our dosing is different than what we see with, the other kind of brand names. And also we can tailor it up and down differently than they can. But we do need to add a medication to it or something to it as well. So as Nash mentioned, there's a bunch of different options that you see out there, B12. B12 helps with fatigue and energy. One of the things that we're starting to see as more people are on these weight loss medications are the amount of nutrient deficiencies that are popping up. B12 being a big one. Calcium, we're seeing a lot of deficiencies as people, basically, if we talk about going into kind of starvation and eating less, we're seeing a lot of deficiencies, especially with the American diet. It's not super high in these type of vitamins anyway to begin with. So we're seeing a lot of that. So B12 helps protect against that. People say they see a lot of fatigue with the medication. Again, B12 kind of helps with that because, again, we're getting kind of B12 deficient. Even if not like medically deficient, you're going lower than you were before, so you kind of feel the effects. They'll mix it with B6. B6 helps a lot with nausea. So it is added for there. People that are very sensitive to nausea medications, that helps. NAD plus, as you mentioned, Nash, is basically an energy driver. So it does help increase energy, can reduce some of that fatigue. And again, it's another thing that we are kind of deficient in when we go into kind of an energy crisis. So it does need to be mixed with something. It does need to be slightly different dosing. So you will see that if you're using a reputable company and a reputable pharmacy, you will see that. Things to be concerned about. Generally, the mix-ins are at a low enough dose that they aren't really they aren't really like a therapeutic dose. So if you were actually very low on B12, your dose would be double or triple what you're getting through our shots. So our shots are more just trying to replicate your dietary intake and not really trying to catch you up. So you're really not going to overdose with it. There's not really any issue with it. Someone else mentioned in there the B12 is red, so you will get that kind of red tinge if it's B12. Sometimes the B6 is a little yellow straw-like color, but B12 is red. So I always warn people, it looks like blood when you pull it up sometimes in the syringe. So they're like, someone put blood in my syringe, but no, it's just the B12. Um, so,
And
so
for those, just a tangent, for
okay.
those who don't know the medical terminology used for B12 is either called methylcobalamin or cyanocobalamin. And cyanocobalamin does not necessarily mean that there's cyanide in it, which is a poison. It's just a name. So I've seen some videos, people are saying that, oh, this is like now they're poisoning you with cyanide. No,
Right,
it's just vitamin B12. It's a
right,
name for it. Like vitamin C is called ascorbic acid.
right.
So yeah, but that's really helpful, and I generally think like, yeah, some of the questions that people are answering, like they just generally are concerned, and it's good for us, or like especially as you as a provider, for us to be able to put ourselves out there to be able to address these questions
Mhm.
that are really concerning to some of the patients that we actually want to know. Like, and there are some people who are just concerned, and so we're here for them, and we just want to put ourselves out there.
Yeah.
We're gonna address one more question, and we're gonna let you go. I don't know if you're excited about the football game right now that we have going on for the final game. First of all, in the chat, if you guys want to like drop down who you're supporting, are you guys supporting Argentina or Spain? Hopefully we'll get some responses here. But I know I'm supporting Spain for
Yeah.
today. I'm always going to be. I've always been an Argentina fan, but I don't know for what reason I want to like support Spain today. So, okay, we'll go ahead and address one other question. So, okay, it's actually one of our patients. So we will try to prioritize them, and they're a fan of Spain too. Perfect. So, and Argentina. Okay, and some Spain. Okay, so we have the patient is on week 6. It seems like their weight loss has been stalled. the patient is concerned on whether or not there is something wrong with their dosing or what's going on with them. First of all, you can always reach out to us. You have the text available to you. Matter of fact, do it right now. You can say, schedule a call with one of our doctors. Just make sure that you do that. But to address their question right now, what do you think is the reason why that their weight loss has been stalled, or like it's like slowing down
Right.
on week 6?
So again, there's a couple of reasons. Again, the scale analogy I think fits. So when we first start, I think one of the most common complaints we get is, yeah, I've been on this for 2 weeks and nothing's happening. And the truth is, the way these medications, the way the way the protocols are designed, and a lot of this is copied from the studies with the brand name medications. We start at a really low dose. Again, if we jump too fast, too far, too fast, and people get really sick. So it's not great. It can be frustrating, but kind of taking the steps, let your body adjust, step up, and slowly kind of turn that scale down into the negative balance when you start to lose weight. Um, the other reason for a stall, again, like we talked about, is as you lose weight, your body actually fights to retain the weight. We talked about, losing weight. You use less energy during the day. So that's one of the ways that we kind of stop losing weight, because we're burning less energy during the day. Your body also releases hormones. As we're adding hormones here, they're adding hormones here to try to balance it back out. And eventually you'll kind of hit a weight where you sort of equilibrate in the middle. Especially when you're doing the steps, you might, when you do the first step, you might say, I went up to, week 5, I increased my dose, and yeah, I lost like 5 or 6 pounds. And then week, 6, I lost a pound. And then by week 7, I kind of flattened out. Well, yeah, because you kind of tipped it a little bit and they kind of worked itself back up. And then when you do the increased dose again, you'll tip it again and kind of work yourself back out, and tip it again and work yourself sort of back out. But these aren't medications. We talk about the testosterone versus, peptide difference. These aren't medications where you just burn calories forever. Eventually, you kind of get down to an equilibrium point, and that equilibrium point changes with each dose. So if you sort of flatten out, then we need to do either increase the dose, or for our max dose, think about either adding something else or think about things that we can do